Okay, so ready to dive into these new ECM guidelines on ARDS treatment. It's like the ultimate cheat sheet, but way more interesting than our average cram session.
Definitely more interesting.
Haha, right. You shared some seriously good stuff with me. The guidelines themselves, a whole bunch of recent studies, and even some thought-provoking commentaries.
Yeah, it's a lot to unpack.
It is. But that's what we're here for, right? To break it all down into those key takeaways that matter, whether you're prepping for rounds, getting ready to give a talk, or just insanely curious about what's new in the world of ARDS.
Sounds good to me.
All right, let's do it. And speaking of new, the guidelines jump right into a debate about the very definition of ARDS.
Which you'd think we'd have figured out by now, right?
Yeah, you'd think so. But the guidelines actually say that with all the advances in treatment, especially things like high-flow nasal oxygen or HFNO, the old definition might be a little too narrow.
Yeah, they make a good point.
Right. Like they specifically question if patients on HFNO should be considered for the ARDS oxygenation criteria, even if they're not on an actual ventilator.
And that's a tough one.
It is. Because a lot of these patients are really struggling to breathe and getting a ton of oxygen support through HFNO.
So it makes you wonder, are we missing potential ARDS cases just because they're not on a ventilator? And that leads to an even bigger question about whether relying solely on oxygen levels, like that PO2/FiO2 ratio, is really the best way to define ARDS.
Yeah, and it gets even more complicated, right? Because the guidelines also mention some issues with using the acute-FiO2 ratio, which is another way to measure oxygen level.
Oh, right.
Yeah, apparently, it can be less accurate in patients with darker skin or who have circulation problems, so it's not a perfect measure either.
I see what you mean.
And then there's the good old chest X-ray.
Ah, the classic.
I know, right? The current definition relies on seeing those telltale bilateral opacities on an X-ray.
Yeah.
But the guidelines point out that interpreting X-rays can be kind of subjective, and in some places getting an X-ray quickly isn't always easy.
Yeah, they bring up a good point.
And they even suggest considering lung ultrasound as a potential alternative, which makes sense because you've probably been seeing more and more about lung ultrasound lately.
Oh, yeah, for sure. It's definitely becoming more common.
It's definitely gaining traction. It's often faster than getting a chest X-ray, and it gives you that real-time view of what's happening in the lungs.
Which is super helpful.
But here's what I found really interesting, and I think you will too. The guidelines actually call out a major omission in the current ARDS definition.
Ooh, what's that?
Inflammation.
Oh, wow. You're right.
It seems kind of obvious when you think about it. ARDS is an inflammatory process at its core.
It is, like the very heart of the condition, and yet the current definition is laser-focused on oxygen levels and completely ignores this whole inflammatory storm happening underneath.
Right. And the guidelines really highlight the need for a definition that captures that complexity.
And not just that, but also the need to consider individual patient responses. It's not a one-size-fits-all situation.
Exactly. So as you're thinking about this first part of our deep dive, here's something to chew on. Is the current definition of ARDS outdated? How much weight should we give to these new diagnostic tools? And what about those biomarkers everyone's talking about? Could those be the key to a more personalized approach to ARDS?
Such good questions. And we're just getting started. Now let's unpack this whole idea of ARDS subphenotypes. So you're probably thinking, what exactly are these subphenotypes and why should I care?
Well, I am wondering that.
Okay, well, think about it this way. If ARDS is like a giant puzzle, right?
Yeah.
Subphenotypes are like finding those edges and corners that help you start to put it all together.
Okay, I like that analogy. Makes it a little less intimidating.
Right. So within this big puzzle of ARDS, there are actually different subgroups of patients, each with their own little quirks and potentially even different responses to treatment.
So it's like saying not all ARDS is created equal.
Exactly. And that's where all those terms they lay out in the guidelines come in handy. You've got your phenotype, which is like the big picture, like we said, ARDS itself. Then you've got your subgroups, which are just smaller groups within that big picture. But the lines between them can get kind of blurry.
Okay, I'm following so far.
But then there's the subphenotype, and this is where it gets really interesting.
Okay, now I'm intrigued. Tell me more.
So a subphenotype is a distinct subgroup that we can actually identify based on specific traits. Think of it this way. If all the ARDS patients with a certain subphenotype walked into a room, you'd be able to pick them out from the crowd.
Because they'd share some key characteristics.
Yeah, exactly.
So what's the holy grail here? To be able to tailor treatments based on these subphenotypes.
Bingo. Imagine being able to look at a patient's subphenotype and say, okay, because of this, we know this treatment is much more likely to work for you. That's the dream, and we're actually starting to see some hints of it in recent studies.
Like that HARP-2 trial the guidelines mentioned. Something about using simvastatin for a specific subphenotype. Refresh my memory on that one.
Right, so the HARP-2 trial looked at patients with what we call a hyperinflammatory subphenotype. Basically, these patients have this supercharged inflammatory response going on. And what they found was pretty interesting. Simvastatin, which you might know as a cholesterol medication, seemed to actually improve outcomes in these specific patients.
Oh, wow. So a common medication potentially having a big impact on a specific group of ARDS patients? That's a pretty big deal.
It is, but, and this is a big state, but being able to accurately identify those subphenotypes is absolutely crucial. The guidelines actually highlight another study, the LIVE trial, where misclassifying subphenotypes led to worse outcomes.
Yikes. Talk about a high-stakes situation.
Yeah.
We're talking about potentially helping or harming patients based on these classifications.
Exactly, which is why having those fast, reliable ways to identify these subphenotypes in real time is so important.
Which leads us to the million-dollar question.
Mm-hmm.
How stable are these subphenotypes? Do they stay the same throughout a patient's illness, or can they shift and change?
Those are the questions researchers are trying to figure out right now, because if subphenotypes can change over time, that could dramatically change how we approach treatment.
So it's not just about identifying them, but also about understanding how they evolve over time?
Exactly. And as you keep reading about subphenotypes, here's something else to think about. What are the long-term implications?
That's a good point. We often get so caught up in dealing with the immediate crisis that we forget about the long game.
Right. So as you're going through those studies, ask yourself, how will these subphenotype-driven treatments impact a patient's recovery a year from now, 5 years from now?
Such an important point. Okay, so we've tackled the definition of ARDS, and we've dipped our toes into the world of subphenotypes. Let's move on to the bread and butter of ARDS management, respiratory support.
Let's do it. We've got a lot to cover, from HFNO to the ins and outs of mechanical ventilation.
Sounds like a plan. First up, let's unpack those HFNO studies you flagged. It seems like this is a hot topic in the guidelines.
It is. HFNO has become super popular in recent years, especially after COVID. And the guidelines spend a good chunk of time comparing different respiratory support strategies.
Okay, well, let's break it down. What does the research say about using HFNO versus just sticking with conventional oxygen therapy?
Yeah, so when we talk about lung protective ventilation, we're really talking about using the ventilator in a way that minimizes further damage to lungs that are already in a super fragile state.
Basically shifting away from that old bigger is better mentality.
Exactly. It's about finding that sweet spot where we're giving enough support but not overdoing it and actually making things worse.
Right, like those lungs have been through enough already.
Right. We're aiming for smaller, gentler breaths to reduce the stress and strain on the lung tissue. Imagine you're handling a delicate piece of fabric. You wouldn't want to stretch or pull it too hard.
That's a good way to put it. So low tidal volume ventilation is a big part of this, right?
It is. Instead of those big breaths to normalize blood gases, we're using smaller breaths with the main goal of protecting those lungs. And yeah, that might mean we sometimes have to accept slightly higher carbon dioxide levels than we're used to.
So it's a different way of thinking about ventilation, for sure. More about protecting the lungs and less about those numbers on the screen.
Exactly. And this shift is based on a much deeper understanding of how ARDS actually affects the lungs at a microscopic level.
So it's not just about throwing more oxygen at the problem, it's about being smarter about how we deliver that oxygen.
Exactly. The guidelines dug into a bunch of studies comparing this low tidal volume ventilation to the traditional approaches. What did they find? Well, the data on mortality benefits isn't crystal clear, but the logic behind it is very solid.
So even if the studies aren't totally definitive, the idea behind it makes a lot of sense.
Exactly. We know that overinflating those delicate air sacs can cause damage, so it makes sense that protecting them with lower tidal volumes would be a good thing.
Right. It's like that old saying, first do no harm.
Exactly. But then the question becomes, how do we figure out the optimal tidal volume for each patient? Because it's not one size fits all, right?
Right. You wouldn't just buy a suit off the rack and hope for the best.
Exactly. You need the right fit. And that's what researchers are trying to figure out with tidal volumes. Instead of a one-size-fits-all approach, we need to individualize it based on the patient's lung mechanics, their overall health, and how they're responding to the ventilator.
So it's about getting to know those lungs really well.
Exactly. The future of ARDS management is all about personalized care, and that definitely includes personalized ventilation strategies.
Okay, so we've talked tidal volume. Now what about PEEP? Seems like there's always a debate about the best way to manage PEEP.
It's true. PEEP, or positive end expiratory pressure, is a little bit like leaving some air in a balloon after you exhale. It helps keep those tiny air sacs, the alveoli, from collapsing, which makes gas exchange way more efficient.
I get the concept, but how much PEEP is enough? And how much is too much?
Million-dollar questions, right? The guidelines looked at different PEEP strategies comparing higher to lower, but neither one really came out on top in terms of mortality.
So no magic number for PEEP.
Yeah.
Are there any hints that can help us make those decisions at the bedside, though?
Well, they did find that higher PEEP levels seem to be linked to more ventilator-free days, which is pretty significant.
So even if it doesn't necessarily mean living longer, it could mean spending less time hooked up to a machine. That's a big deal for patients and their families.
It is. But we always have to remember those trade-offs. Higher PEEP can come with risks, too, like barotrauma, where the high pressure actually damages the lungs, and hemodynamic instability, where it affects blood pressure and circulation.
So it's always a balancing act, weighing those potential benefits against the potential downsides.
Exactly. And again, it highlights why individualized care is so important. What works for one patient might not work for the next.
The guidelines also mention a couple of other PEEP strategies, mechanics-based PEEP, and then using those PEEP/FiO2 tables. Can you break those down for us?
Sure, so mechanics-based PEEP is all about adjusting the PEEP level based on how the lungs respond to pressure and volume. It's about finding that sweet spot where we're optimizing how well the lungs are working without pushing them too far.
And the PEEP/FiO2 tables.
Those are basically predetermined combinations of PEEP and FiO2 levels, kind of like a roadmap. The goal is to achieve good oxygen levels using the lowest possible PEEP.
So two different approaches to the same problem. What's the bottom line?
It's still a bit up in the air, honestly. Both strategies have shown some promise in studies, but there's no clear winner. It seems like the key takeaway is that we need to individualize the approach based on what each patient needs.
So it's back to personalized medicine.
You got it. It's the future. Now, another intervention related to ventilation that we should talk about is recruitment maneuvers.
Oh yeah, those are the maneuvers where we're trying to open up collapsed areas of the lung, right?
Exactly. And the guidelines are actually very clear about their recommendations here. They strongly advise against prolonged high-pressure recruitment maneuvers.
Because of the risks.
Yes. The research shows that the potential harms of these maneuvers, things like pneumothorax, which is basically a collapsed lung, and even cardiac arrest, outweigh any benefit they might offer.
So prolonged high-pressure RMs are out. What about doing those brief high-pressure maneuvers?
They're a little more nuanced. The guidelines say to use those cautiously and only in very specific situations where the potential benefits are worth the risks. For example, they might be helpful in reopening some collapsed areas after suctioning or changing a patient's position.
But definitely not something to do routinely.
Yeah.
What about those periodic sigh breaths that the guidelines mention? What's the deal with those?
Those are interesting. They're gentler maneuvers that could potentially help prevent lung collapse during low-pressure ventilation. More research is needed, but it's a promising area.
So sigh breaths, potentially a good thing, but we need more data.
Exactly. Now, shifting gears a bit, another intervention that's been getting a lot of attention lately is prone positioning.
Right. It seems like everyone's talking about prone positioning these days. It's become pretty standard care for a lot of patients with moderate to severe ARDS, hasn't it?
It has. And for good reason. The evidence supporting prone positioning is pretty strong, particularly in those patients with really low blood oxygen levels.
And just so everyone's on the same page, prone positioning basically means placing the patient on their stomach, which sounds incredibly simple, but clearly is doing something helpful.
It really is simple, but it can make a big difference. The guidelines talk about this landmark study, the PROSEVA trial, which showed a significant reduction in mortality in patients who were placed in the prone position.
Wow, a reduction in mortality. That's huge. Why does it work so well?
It seems to work on a few different levels. One thought is that it improves ventilation perfusion matching, which basically means it helps make sure that the air we're getting into the lungs with the ventilator is actually reaching the areas where there's good blood flow, so you get better oxygen exchange. It can also help redistribute fluid in the lungs and reduce the overall stress on the lung tissue.
So it's not just about giving the lungs a break, it's about helping them work more efficiently.
Right, and the guidelines actually recommend keeping patients in that prone position for at least 16 hours per day.
16 hours, that's a long time.
It is. But it seems like the sweet spot to really maximize the benefit. Of course, we still need more research to figure out the ideal duration and when it's okay to stop proning altogether.
Sounds like a research opportunity to me. What about this awake prone positioning, or APP, I've heard about,
Yeah.
for patients who aren't intubated?
Yeah, good catch. So that's where we encourage patients to spend some time lying on their stomachs while they're still awake. It's gained some traction as a potential way to prevent the need for intubation in the first place, but more research is needed to really know how effective it is.
Interesting. Okay, so prone positioning, another tool in our toolkit. Now let's talk about something a little more controversial. Neuromuscular blocking agents, or NMBAs for short.
Ah, yes.
Yeah,
These are the medications that cause temporary muscle paralysis.
yeah, these were always a little intimidating to learn about back in school.
I can see why. They're definitely not for every patient. The initial idea behind using NMBAs and ARDS was that they could improve lung protection by synchronizing the patient's breathing with the ventilator.
So taking away that fight or flight response that some patients have when they're critically ill and on a ventilator.
Exactly. But here's the thing. ICU practices have evolved a lot since those early studies on NMBAs. We're much better now at lighter sedation strategies and getting patients moving earlier, which we know is so important.
Makes sense. Keeping someone sedated and immobile for days on end comes with its own set of problems.
Exactly. And as it turns out, the guidelines highlight a recent study, the ROSE trial, that showed no mortality benefit to using NMBAs early on in ARDS compared to a lighter sedation approach.
So no clear advantage when it comes to survival.
Right. Which suggests that routine use of NMBAs probably isn't necessary, but they might still have a role to play in specific situations, like preventing a pneumothorax in high-risk patients.
So it's about being really thoughtful about when and how we use these powerful medications.
Absolutely. And we always have to weigh the potential long-term effects, things like muscle weakness or the psychological impact. Those are things we need to consider.
It's true, we're only just beginning to understand the long-term consequences of critical illness, and it's not always pretty.
It's not. And it's definitely something to be mindful of with any intervention we use, not just NMBAs.
Okay, so NMBAs used with caution and only when absolutely necessary. Now, what about ECMO, the elephant in the room? The intervention that's often seen as the last resort.
Right. ECMO, which stands for extracorporeal membrane oxygenation, is basically an artificial lung. It oxygenates the blood outside of the body, which gives the lungs a chance to rest and hopefully heal.
It's an amazing technology when you think about it, but it's also incredibly resource intensive and not without its risks.
Very true. ECMO is really reserved for those most severe ARDS cases. And even then, it's not a guarantee. The guidelines do recommend it for patients with severe ARDS who meet certain criteria. And the good news is that studies have shown it can improve survival rates in this very sick patient population.
So it can be a lifesaver for those who need it.
It can, but it's important to remember those limitations. It's not a cure-all, and it comes with its own risks.
It's a big decision to consider for everyone involved.
Yeah.
The patient, the family, and the medical team.
Oh. Absolutely. It's a conversation that needs to happen with everyone weighing those potential benefits against the potential risks very carefully.
The guidelines also address ECCO2R, which is ECMO, specifically for carbon dioxide removal. What's the verdict on that one?
They actually recommend against using ECCO2R for ATORTs right now. The research just hasn't shown that it improves outcomes, and it might even increase the risks.
So sometimes less is more.
Exactly. Well, we've covered a ton of ground in this deep dive into ARDS treatment, from defining ARDS and understanding those different subphenotypes to all the ins and outs of respiratory support and lung protective ventilation.
We've talked about the controversies, the uncertainties, and the glimmers of hope that are shaping the future of ARDS care. It's a lot to take in, but super important stuff for anyone caring for these patients.
It is, and if there's one thing I hope listeners take away from this deep dive, it's the importance of that personalized approach. There's no one-size-fits-all solution for ARDS.
So it's about really understanding the individual patient in front of you and tailoring your approach to their specific needs.
Exactly. And as new research comes out, we need to stay informed, stay curious, and always be asking ourselves how we can provide the best possible care.
Well said. This has been a fantastic deep dive into these new ECIM guidelines on ARDS treatment. For everyone listening out there, thanks for joining us on the deep dive. Keep learning, keep questioning, and keep pushing for the best possible care for your patients.